Hi, this is Piyush Bhargava and you're watching the GI bleeding scan teaching file. Let's quickly review the protocol for doing these studies. The GI bleeding scan is typically performed when the patient's present with passing bright red blood per rectum or they have a lower GI bleed, which we also call hematochezia. The radiopharmaceutical use for this study is 20 millicuries of technetium labeled red blood cells which are injected IV. Dynamic images of the abdomen and pelvis are acquired in an anterior projection at 1 minute per frame for 60 minutes. And when we see any abnormal activity we want to evaluate further, then we do a SPECT or a SPECT CT. The mechanism of uptake of this radio tracer is blood pooling inside the intravascular compartment. So physiologic distribution shows activity in the spleen, also from blood pooling and also in the intravascular compartment. The critical organ for this radiopharmaceutical is the spleen. Case number 1 shows multiple images from a negative bleeding scan. This patient was passing bright red blood per rectum, but when we scanned them over a period of an hour, we didn't see any evidence of bleeding. So one of the purposes of doing the bleeding scan is, like I said before, to localize the site of GI bleeding, whether it's coming from the celiac artery branch, SMA branch, or an IMA branch, and also to differentiate between patients who are at high risk of bleeding and need immediate intervention versus patients who are at low risk of significant bleeding and their bleeding is intermittent. So bleeding scan helps us differentiate between those two categories of patients as well, and their further management in terms of angiography and trying to stop the bleeding is different. In patients who are bleeding rapidly, you may want to do the procedure immediately, and the patients who present with intermittent bleeding, we can have a more of a wait and watch policy on those patients. So let's look at these images. These are 4 sets of 15 minutes, 15 images each. The first 15 minutes, second 15 minutes, the third and the fourth 15 minutes. As we look at these images, we find that at the top of the image there is activity inside the ventricles, which we see partially at the field of view. Then there is faint activity in the liver, some activity in the spleen, and then we see the aorta and the RBC and their branches. So that's a normal distribution of the tracer. As we go through these images, we find that there is no evidence of an abnormal focal uptake that appears and moves in the pattern of the bowel to suggest presence of active GI bleed. So this is a negative study. Now let's look at a positive scan. This is case number 2, and this is a dynamic acquisition, and I will play it as a cine. So here, if you look closely, you will find that there is an abnormal focus that appears in the left upper quadrant right here, and then the activity moves inferiorly towards the right and then curves and then goes towards the cecum. Let me play it one more time. So the abnormal focus appears here at the splenic flexure of colon, and the intraluminal blood, since it's an irritant, it can go antegrade in the bowel and it can go retrograde in the bowel. And here we see retrograde passage of the blood, which goes from the splenic flexure back into the redundant transverse colon and then into the hepatic flexure of colon and into the cecum. So the site of bleeding is here in the watershed region in the left upper quadrant at the splenic flexure of colon. Another positive bleeding scan. Here, as we go through the images, we find that the abnormal focus again appears here in the left upper quadrant in the region of the splenic flexure of colon, and as we follow this focus, we find that the activity goes more antegrade in the pattern of the descending colon, which is best seen here, and then into the sigmoid colon. Towards the end, we see some physiologic urinary bladder activity as well. Next case, number 4, shows abnormal focus in the right upper quadrant at the hepatic flexure of colon, and as we follow this activity moves in the pattern of the transverse colon in an antegrade distribution, and also towards the end we find that there is some activity that has gone retrograde into the ascending colon and the cecum. So this patient is bleeding from the hepatic flexure of colon. So you want to recognize the first image where that abnormal focus appears, and then in the next images follow that focus and see what pattern of bowel does it move in form of, and then make a diagnosis of where the patient is bleeding from. This is an interesting one. As we go through the images, we find that there's a focus of abnormal activity that appears right here above the urinary bladder, and then it goes away. And then as we go further, we find that it appears again right here, and then over a period of time it goes away. And then the fourth set of images is negative. So here we find that the scan is positive, the focus appears and disappears 2 times in the entire acquisition, and it is seen right above the urinary bladder, which would be the region of the sigmoid colon. So this patient is bleeding from their sigmoid colon. Case number 6. Here, as we go through the images, we find that there is an abnormal focus that appears right here in the left upper quadrant. And as we follow this focus, it comes down, curves around, and as we follow it further, we find that the activity has gone antegrade into the descending colon and also gone retrograde into the transverse colon. So here the site of bleeding is again in the splenic flexure of colon. Another bleeding scan on case number 7. This is a great example of a small bowel bleed where the abnormal focus appears here in the region of the first or the second portion of the duodenum, right there, and then the activity moves distally and also proximally into the stomach. So this is a good example of a small bowel bleed. Last case for this teaching file, and this shows an artifact. This patient presented with passing bright red blood per rectum, and we injected them with autologous red blood cells labeled with 20 millicuries of technetium 99M. And as we started acquiring the images, we found that on the first set of images, 1 minute per frame, there is uptake in the stomach. Stomach becomes more intense, but the activity does not move. So the uptake is in the wall of the stomach, and that is telling us that there is probably inefficient labeling of the red blood cells. There is a lot of free tech in what was injected in the patient, and because of which there is uptake in the stomach, there is excretion from the kidneys into the urinary bladder. And to confirm it, we took a picture of the head and neck region where there is uptake of free technetium in the thyroid, in the salivary glands, and in the oral cavity. So this is a great example of an artifact from inefficient labeling of red blood cells. So those are some of the common patterns that you can encounter when you're reading the GI bleeding studies. Thanks for watching.